today I'm going to talk about a disease of stomach called as Congenital Hypertrophic Pyloric Stenosis. When I was a student and a teacher, I used to call it Congenital Hypertrophic Pyloric Stenosis. But over the last 40 years, the nomenclature has changed. It is now called as Hypertrophic Pyloric Stenosis or infantile hypertrophic pyloric stenosis, because people realized that it's not a congenital disease. The hyperplasia of the pylorus starts after birth. Therefore, name has been changed into HPS, hypertrophic pyloric stenosis, or infantile hypertrophic pyloric stenosis. I think this is a better name, RHPS. The incidence quoted in the Western literature is 1 in 3,300 live births. The incidence in India, I do not know. As the name is so explicit and self-explanatory, there is a hyperplasia of the pyloric muscle, pyloric sphincter, leading to blockade of the pylorus. Etiology of this disease is not known. For some reason, the pyloric muscle undergoes hyperplasia after birth. Most of them present during 2 to 8 weeks of life. Presentation after 13 weeks is extremely unusual. Etiology of this disease is not known. Why pyloric muscle undergoes hyperplasia and hypertrophy to block the pylorus, God alone knows. What we know is, number one, it presents during second and 8th week of life. It is more common in males than in females. Its proportion given is 4 to 5 males to 1 female. But a female who suffers from a disease in childhood is likely to give birth to a child who has HPS. Pathologically, there is a hyperplasia of the pylorus. Size is about 5 to 6 millimeters. Length is about 1.15 millimeters. The proximus stomach dilates. Proximus stomach muscle undergoes hypertrophy. There is a stress gastritis. Pathologically, the tumor is round or longitudinal, situated at the pylorus. Clinical presentation, except that it has a hereditary predisposition, no other geological factor has been blamed. Pathologically, the tumor consists of circular fibers of the sphincter of pylorus spreading over pyloric region, leading to complete narrowing of first the mucosa crumples, and then it leads to total blockade of the lumen, leading to complete obstruction of pylorus, leading to proximus stomach dilatation, stress gastritis, and hypertrophy of the stomach muscles. Clinical presentation, the child is failure to thrive. The second common feature is vomiting. The characteristic vomiting is projectile and forceful. It contains all the milk which the child has swallowed. The vomiting comes 2 to 3 hours after a feed. Initially, vomiting is less prominent. As the time goes and disease matures, the highly projectile vomiting is a very classical feature of pyloric stenosis. The child gradually loses weight. The hunger persists. The child wants to suckle. But the vomiting after 1 to 2 hours after meals, which is projectile, contains whatever was taken by the child, is a very classical feature. The child develops hypochloremic, hypokalemic alkalosis, dehydration. The stools become infrequent, passing of gases become infrequent, and child starts losing weight. Such presentation is so classical. Clinical examination, apart general examination shows the child is thinned out, has frank signs of dehydration, is listless and dizzy because of hypochloremic alkalosis. Clinical examination reveals a visible peristalsis. Visible peristalsis, which is classical. It starts in the left hypochondriac region and goes downwards and medially and ends at a point about an inch above the umbilicus. The visible peristalsis is so classical. For this to demonstrate, you need to ask a mother to feed a child. The second important sign which clinches the diagnosis, a feeling of a pyloric tumor. Why is it called as tumor? I don't know, but you feel it as a fairly tough mass, like an olive, just above the umbilicus, to the right and above umbilicus. For this, the stomach must be empty. However smart a doctor may be, the child cries the moment he sees the doctor. To stop this or examine the pyloric tumor, which is a clinching point in diagnosis, you ask a mother to take a child in her lap and ask her to feed a child. Ask a child, stomach should be empty before that, but you ask a child to feed and cover the child so that he doesn't see. And a clinician puts his left hand on the abdomen of a child, somewhere somewhere above the umbilicus, to feel a nice knotty mass. The hyperperistalsis, projectile peristalsis, sometimes hides this tumor. Therefore, the stomach should be empty when you are palpating tumor. These two signs, visible peristalsis, classical of stomach, and palpating olive-like tumor, clinches the diagnosis of hypertrophic pyloric stenosis. Sometimes, general examination, of course, shows signs of dehydration, tachycardia, dry tongue, loss of elasticity of skin, and a dizzy and listless child. Sometimes the tumor is not felt. The reason for it is sometimes the child presents early, before the tumor is well formed, or in children, the left lobe of liver is known to cover large part of stomach. Sometimes the tumor is get covered by left lobe of the liver. In such a situation, ultrasound is a wonderful investigation. Ultrasound shows a pyloric tumor about 5 to 6 mm in size. The pyloric canal about 15 millimeters, totally narrow, and shows proximal dilated stomach. The diagnostic efficiency of ultrasound is 95 to 98%. But this is not required as a routine investigation. As and when you have a problem, you do ultrasound. There are few causes of vomiting which must not be confused with hypertrophic pyloric stenosis. One is esophageal gastric reflux, UTIs, gastroenteritis, metabolic disorders, but all of them do not have this classical feature of vomiting, which is forceful, vomiting which comes after feeds, and vomiting which shows visible peristalsis. And persistent vomiting over a period of time, which is projectile, is a very, very classical presentation. I think the other causes of vomiting are very short-lived. They don't have these features at all, and they are mentioned for not reaching a direct conclusion of hypertrophic stenosis, because none of these diseases need surgery. Hypertrophic pyloric stenosis needs surgery. Treatment is surgical only. There is only one operation described. The surgery for hypertrophic pyloric stenosis is never an emergency surgery. It's always planned. Minimum time you spend in preparing a patient for an operation is 48 to 72 hours. The time related is also related to the amount of dehydration and alkalosis caused by the disease. By and large, pediatrician tells you what to give, but how we treat the patient is after hospitalization, passing 8 to 10 French rice tube in the stomach, empty the stomach. Saline washes are given to clear the stomach. Intravenous drip is started. Usually give 150 to 180 ml of per kg per day normal saline, 0.9%. Add to it 50 cc's of 0.15% potassium chloride in a 5% glucose. Both the drips run simultaneously. The correction of dehydration alkalosis is told to you by disappearance of signs of dehydration. The tongue becomes weak, the child becomes more active, the alkalosis disappears, urine output improves, patient starts passing gases, and anesthetist ultimately decides the fitness of patient. The surgery is done under usual general anesthesia. Both the approaches, open operation and laparoscopy, both are equally successful. There's a trend of doing laparoscopic pyloromyotomy. It's called as by laparoscopic operation. This operation is called as Ramsted's pyloromyotomy. This is also, some books mention it, Fredette-Ramsted pyloric mytomy. The name Fredette is added because Fredette, there's a story behind it. Fredette was doing operation, maybe 100 years ago. He was planning a gastroduodenostomy for this disease. He incised the pyloric muscle, and the patient's condition deteriorated. Anesthetist asked him to stop. He came out and closed it, and they realized the vomiting stopped. Obviously, Ramsted took an opportunity to isolate it, doing pyloromyotomy only without entering the duodenum, without doing any kind of anastomosis. Therefore, the operation goes by his name, called as Ramsted's pyloromyotomy. In open surgery, you give an incision either vertical midline just above the umbilicus or transverse incision above the umbilicus to the right, which goes through the right rectus. Better incision is transverse right incision, which is directly put on the tumor. Laparoscopic is better, especially in females. After you open the abdomen, because the pylorus is mobile, you deliver the pylorus out. One thing which I forgot to tell you in pathology was the tumor becomes larger and projects in the lumen of duodenum. Duodenal mucosa covers the projecting tumor inside the lumen, producing something like fornix. And a fornix, everybody knows, as cervix enters vagina, there is a fornix. Exactly same fornix is created around the pyloric tumor. When you incise the serosa, pull the tumor out, inside the serosa, be careful not to extend on the stomach. Because that's the place where you are likely to damage the mucosa. And the incision is never deeper than mucosa. The rest of the things are done by either spreaders which are available. And in our times, we used to do it by a blunt artifices. You easily separate the muscle right from entire length of the tumor, taking care that you don't damage the mucosa. You ask an anesthetist to inject few cc's of air and then press on the proximal stomach to find out whether the fluid and gas passes easily into duodenum. It will definitely pass. The most important is the entire mucosa bulges in the incision or thread of pyloric muscle you created. The mucosa must bulge equally along the entire length of your incision, allowing the fluid and gas to pass into the duodenum. That's complete operation. A few bleeders, you can contract them and close the abdomen. Post-operatively, the IV continues for another 24 hours. Same solution which you gave. The oral starts after 24 hours. The The solutions are available, pediatric solutions are available, but sterile water, such slight amount of salt is enough. The breastfeeding starts after 24 hours, and post-operative patient can be discharged in 2-3 days. The complications are two, mainly. Number one, persistent vomiting, which indicates incomplete operation. Some fibers of pyloric muscle was left out, not cut. The only treatment is redo it. And second is injury to the mucosa at the time of surgery, especially in the fornix. It must be demonstrated there and then. As I told you, we put you gas in the stomach and try to push. This maneuver will detect a perforation, which must be closed. In a situation where perforation is created, the oral starts not less than 48 hours. It must start later. The results are excellent. This operation was described almost 100 years ago, and the steps have not changed. The name of the operation has not changed. There are no modifications in the operation. This is one of the very, very rare examples of surgery where a disease whose etiology is not known, but the operation is absolutely fantastic, where no modification was described for this operation. The disease has today walked out in the hands of pediatric surgeons. General surgeons hardly face it. But what patient to refer to a pediatric surgeon? The general surgeon as well as an MBBS boy must know. Therefore, hyperplastic pyloric stenosis. Thank you.